On behalf of the American Heart Association, I would like to welcome you to today's webinar, Implementation Strategies to Improve Blood Pressure Control in the United States. Before we begin, I'd like to quickly review how to use this platform for today's event. If you experience any technical difficulties, most user issues can be resolved by refreshing your browser. If that does not work, please review the system requirements or contact the Zoom webinar helpline. Throughout today's discussion, you will have the opportunity to submit text questions for our presenter using the questions feature on your control panel. You may send in your questions at any time, and we will review the questions during our Q&A at the end as time allows. By email tomorrow, you will receive an invitation to complete our feedback survey. This presentation will be recorded and available within the coming weeks at heart.org/pain management. It is my pleasure to introduce our speaker for today, Dr. Marwah Abdalla. Dr. Abdalla is a cardiologist and Florence Irving Associate Professor of Medicine at Columbia University Irving Medical Center. She is an American Heart Association and NHI/NHLBI funded clinical investigator with research expertise in hypertension diagnosis, treatment, out-of-office blood pressure monitoring using home and ambulatory blood pressure monitoring, and in sleep. She was vice chair of the joint American Heart Association, American Medical Association scientific statement on implementation strategies to improve blood pressure control in the US. Thank you for leading our webinar today, Dr. Abdalla. The floor is yours.
Well, thank you so much for the kind invitation, and I'm looking forward to the conversation at the end. So to start, I have no disclosures. However, I do have the following funding sources from both NIH and the American Heart Association. So basically, the information I'm presenting today is based on our recently released American Heart Association and American Medical Association scientific statement on implementation strategies to improve blood pressure control in the United States. I first want to acknowledge and thank the other members of the writing group of our scientific statement that are listed on the slide. Here's the outline and learning objectives for today. We're going to review briefly the trends in hypertension and blood pressure control in the United States. We're then going to review the key approaches and implementation strategies to improve blood pressure control using the Socioecological framework. Lastly, we'll end with identifying some priorities and critical gaps. Now, this slide shows the age-adjusted trends in the prevalence of hypertension, and here we define it using a cutoff of 140/90 millimeters of mercury. And these trends are also shown by race ethnicity. The data is from the NHANES cohort, depicting 2 time periods. On the left, from 2009 to 2012, and on the right shows it from 2017 to 2020. Now, the study presents data from over 32,000 US adults. Depicted in blue is the overall prevalence of hypertension among US adults, which has remained around 32% over both time periods. Now, the highest prevalence of hypertension has consistently been among Black adults, depicted here in black, and there has been a statistically significant increase in the prevalence of hypertension among Asian and Hispanic adults over time. This is represented here in 2009-2012 in orange, and this light blue color for Hispanic adults. And if you can see that the age-adjusted prevalence has increased in the most recent time period. Here's data also from NHANES, and shows that trends in blood pressure control over time have actually improved from 1999 to the height of 2013. However, after 2013 to 2014, blood pressure control in the United States has actually worsened over time, and this is a concerning trend. Now, we know that some of the factors that have been associated with having uncontrolled blood pressure have been lack of access to care, lack of healthcare insurance, and irregular healthcare visits. And that's data from also using the NHANES cohort, which was published by Paul Muttner et al. In JAMA in 2020. We also know that there's some recent data that shows that the COVID pandemic has continued to exacerbate blood pressure control, although that data has not been currently updated in the NHANES cohort. Now, this figure shows that while systolic blood pressure may be higher across time, here again, this is NHANES data, over 51,000 US adults here. The time periods involved are 1999 to 2002, and then here as well as 2015 to 2018. And this figure shows the systolic blood pressure for individuals not taking antihypertensive medications, as well as those taking antihypertensive medication, subdivided by race ethnicity. And what you'll notice here is that non-Hispanic Black adults are depicted in blue, non-Hispanic whites in red, and in Hispanic adults are depicted in black. Now, across both time periods, you'll note that non-Hispanic Black adults as well tend to have higher blood pressure compared to Hispanic adults and white adults. Now, while the systolic blood pressure may be higher in Hispanic adults, what I do want to note is that the prevalence, if you look at CDC data, is actually lower in this population than white adults. It's most recent data. But here we're showing that high blood pressure is more common in non-Hispanic Black adults than in non-Hispanic white adults. And the fact that over time, this seems to have been increase in systolic blood pressure amongst those with and on antihypertensive medications and those not taking antihypertensive medications. So we have to really examine and think about health disparities in blood pressure control, and those have historic roots. I wanted to call your attention to this AHA Presidential Advisory on Structural Racism as a Fundamental Driver of Health Disparities. And understanding the historical context, which I will not get into during this webinar, is obviously going to be a core strategy and helpful when implementing strategies for blood pressure control. So what have been the current barriers to blood pressure control? Well, they occur at multiple levels, both at the system level, the policy level, the community level, the organization level, as well as at the individual level. And I'd like for you to think about these as we go through the rest of the webinar as to where you particularly may be able to impact and think about blood pressure control. Now, the purpose of our scientific statement was to outline these barriers, but really to provide information on implementation strategies to optimize treatment and improve blood pressure control amongst U.S. adults. And I'd like to first say that an additional barriers, of course, have been guidelines and scientific statements. While guidelines cover definitions of blood pressure and different blood pressure levels, how to measure blood pressure, how to be used, and which antihypertensive medication regimens we should be using, for the most part, with few exceptions, they have not really focused on implementation strategies for blood pressure control, which in itself is a key barrier. Now, the purpose, again, is to focus on the strategies at multiple levels, and we use the socioecological framework to really figure out as to what are the key strategies that can be used to improve blood pressure control amongst U.S. adults. Now, here are the cross-cutting strategies that we identified in the scientific statement to improve blood pressure control. I'll start on the top by saying that these strategies include accurate blood pressure measurement, the use of team-based care, obviously implementation of lifestyle programs, but specifically at the organizational, community, and policy levels. Another strategy is the use of standardized antihypertensive treatment protocols, which would obviously improve and hopefully improve medication acceptance and adherence. We also highlight the use of continuous quality improvement metrics, the use of financial levers, as well as the use of anti-racism efforts. Now, obviously, sufficient funding, and that's what I really like to focus on here, is sufficient funding and shared accountability has to occur at multiple levels of the socioecological framework if any of these strategies really are to work. Now, what we did in the statement is also map out at what level of the socioecological framework each of these strategies targets. So, for example, if you look at anti-racism efforts, obviously they can occur across the individual, organization, community, and policy levels. Whereas others, for example, continuous quality improvement may occur at the individual, organization, or the policy level only. And so what we did through this is weave in what are these strategies and where they actually target in order to provide a conversation with colleagues as to where they think they can be most helpful in the multi-pronged approach to improving blood pressure control in the U.S. Now, the first key implementation strategy is, of course, accurate blood pressure measurement. You can't achieve blood pressure control if we're not measuring blood pressure correctly, and at the core of that, it requires validated blood pressure devices. Now, guidelines recommend the use of automated oscillometric devices, and I highlight here for those who may be interested, and I encourage all of you to visit these two websites, validatebp.org and stridebp.org. Both provide a listing of validated automated oscillometric devices. And what I like to use, even as a clinician, is when I'm sitting in front of a patient to actually pull up and show them what devices have been validated. For those of you who are at the healthcare level, you may want to make sure that the devices that you're offering in clinics and offices are also validated, because that is one of the first key strategies that we really need to make sure that we're moving towards validated instruments in order to make sure that blood pressure control and definitions are uniform. Now, out-of-office blood pressure is also recommended to confirm the diagnosis of hypertension and for the titration of antihypertensive medications across multiple US scientific statements and guidelines, as well as international guidelines. Now, one of the things I'd like to focus on is also to show that self-measured blood pressure, often thought as home blood pressure measurement, in conjunction with telehealth counseling or clinical interventions, is really the strategy that has been most effective, and we'll go through some of that data. Now, first, to make sure that everyone is on the same page, for self-measured blood pressure or home blood pressure monitoring, this is the recommended testing protocol. So 7 consecutive days. Now, there's some data that's been published recently that 3 days of readings may be acceptable, although that 3 days has not yet been incorporated into guidelines. It's usually 2 readings in the morning and 2 readings before bed for 1 week is the guideline recommended approach. Obviously, again, ensuring a validated device, again, why those websites are really important to make sure that our individual patients are looking at that and making sure that they're using the appropriate devices. And what's been shown is that, home blood pressure monitoring is feasible and more available compared to 24-hour ambulatory blood pressure monitoring devices, which often requires hypertension level expertise and is a more expensive out-of-office blood pressure device. Now, obviously, there are some core limitations of home blood pressure monitoring. And again, throughout the webinar, I will use both terminology, self-measured as well as home blood pressure. Over-the-counter devices, as we've mentioned, are often not validated and not always covered by insurance. They often have the wrong cuff sizes. Obviously, many of us who are clinicians have seen our patients come in with a list of just written down of blood pressure readings and the time. Automatic recording is not always available, and telehealth integration is limited for many places. Long-term patient adherence has been challenging, particularly the 7-day protocol. Now, there are CPT codes, both 99473 as well as 99474, that you can bill for home blood pressure monitoring. They're currently underused, and reimbursement is low. It's about $9 to $15 and can only be billed once per device and every 30 days. Now, another question that often comes up is which is superior? Is it ambulatory blood pressure monitoring or home blood pressure monitoring? And there's actually been a systematic review that we published of over 1,000 articles where we looked at that had both ABPM and home blood pressure monitoring. And we only found that there were 9 articles among 7 cohorts that examined whether blood pressure on ambulatory blood pressure monitoring or home blood pressure monitoring is more strongly associated with cardiovascular disease events and or mortality. Now, when you look at the data, if you ABPM adjusted for home blood pressure monitoring, the systolic blood pressure on ABPM was associated with outcomes in 2 out of 4 cohorts for systolic blood pressure, and only 2 out of 3 cohorts for diastolic blood pressure. Now, when you look at the data looking at home blood pressure monitoring adjusted for ambulatory blood pressure, the systolic blood pressure and home blood pressure monitoring was associated with no outcomes when you look at across 3 cohorts and only 1 out of 2 cohorts for diastolic blood pressure. So what we really know from this data is that it's still an unresolved question as to which one is superior. And I think that contributes to some of the barriers as to what we should be using for out-of-office blood pressure monitoring. And to remind everyone, these are the current 2017 ACC/AHA blood pressure guidelines that suggest that for those who are not on medications, that daytime ambulatory blood pressure monitoring is the preferred approach. Home blood pressure is an alternative. Whereas for those who are treated, really recommending the home blood pressure monitoring option first, and second, using daytime ambulatory blood pressure only if the home blood pressure monitoring shows that blood pressure is out of control. Now, we do know that home blood pressure monitoring, there's some data that it shows that it actually may be more reliable, more strongly correlated with target organ damage. I want to show this data from the Improving the Detection of Hypertension study, which is a study of about 400 adults not on antihypertensive medications. And the study compared the reliability of using office blood pressure measured on ambulatory blood pressure monitoring, as well as blood pressure on home blood pressure monitoring. And they looked at the associations of each blood pressure measure with left ventricular mass index. Now, up top on the first table here shows the reliabilities and the intraclass correlation coefficients of both office blood pressure, home blood pressure monitoring, and awake blood pressure on 24-hour ambulatory blood pressure monitoring. And the reliability was highest for home blood pressure monitoring. Now, in this table below, it shows several models just focused on the adjusted models, model 3. And fully adjusted models, higher systolic blood pressure as measured by home blood pressure monitoring was the only one that was associated with left ventricular mass index here at 4.88 grams per meter squared, whereas office systolic blood pressure and awake systolic blood pressure were not associated with left ventricular mass index. So this is intriguing, data that shows that potentially that the home blood pressure monitoring really is the way to go in terms of it being more correlated with target organ damage. So what's the evidence for using self-measured blood pressure for blood pressure control, and why we spent a significant amount of time in the scientific statement talking about this? It shows that, here's some data from meta-analysis of 26 studies, over 6,000 individuals, and the primary outcome was office systolic blood pressure at 12 months. This meta-analysis looked at studies that looked at home blood pressure alone, home blood pressure monitoring plus web-based or phone support, that with home blood pressure monitoring plus a patient education inclusive of phone support, or home blood pressure monitoring with individualized counseling or telecounseling. And overall, whatever strategy you use, self-monitoring was actually associated with reduced office systolic blood pressure at 12 months compared to usual care. And what we noted in this meta-analysis is the moderate or higher levels of support. So for example, these last two here had statistically significant greater mean reductions in systolic blood pressure and diastolic blood pressure, and substantial improvements in blood pressure control, was able to increase blood pressure control between 43 to 56% compared with usual care. So one of the second implementation strategies we focused on was team-based care, and the definition of team-based care is the provision of health services by at least 2 healthcare professionals working collaboratively with a patient. Data from a systematic review of at least 54 studies between 2012 and 2020, which was conducted by the Community Preventative Services Task Force, showed that amongst 21 studies, home blood pressure monitoring was part of team-based care interventions. And when you did that, you were able to show a decrease in both systolic and diastolic blood pressure of about 3 millimeters of mercury and 2 millimeters of mercury across cohorts. Now, the median cost per quality gain was about $15,000. And really, when you think about team-based care, care in community settings has been shown to be effective, whether that you incorporate that in faith-based organizations, pharmacies, and we'll talk about that later on, home outreach visits. And it's really the idea of using team-based care for task shifting for appropriate parts of hypertension control. It also, with team-based care, is an ability to provide a wider availability of self-measured blood pressure monitoring in settings where individuals are in their community settings. So the Surgeon General reports it as people being able to meet people where they sleep, work, and play. So the third key strategy that we identified was standardizing antihypertensive treatment protocols, along with improving medication acceptance and adherence. Now, you may not know, but about 12% of patients with hypertension on first diagnosis actually never fill their initial prescriptions for antihypertensive medications. And what we've shown, it's clear from looking at multiple studies that you really need a multi-component approach to improve acceptance and adherence. One of these approaches, which we definitely highlight in our scientific statement, is the once daily, inexpensive, single dose combination pills that may be within blister or dose packages. And we think that use of these standardized antihypertensive treatment protocols also build upon some of these other key strategies that we just outlined. They facilitate team-based medication titration and team-based care, and obviously will also improve any clinician inertia. This can show up in ways including refill reminders, but I think core to this is really having a financial incentive for patients and care teams. And one of the prior scientific statements that was published last year in 2022, which is great to review, is the led by Nitish Chowdhury. And this is a scientific statement focusing on barriers and strategies to improve medication adherence and blood pressure control, which I highly recommend for those who want to look more into this particular strategy. So now here's an example. I'm going to talk about integrating at least two strategies, right? We talked about team-based care and we just talked about treatment protocols. And for some of you maybe already familiar with this, some work by Ronald Victor's group looking at the use of treatment protocols and team-based care out in the community, again, meeting people where they sleep, work, and play, that concept. And there are two studies here. One was published in New England Journal of Medicine in 2018, and the other one in Circulation as well. And it's looking at a cluster randomized trial of blood pressure reduction in Black adults in barbershops. So let me just start by reviewing the barbershop study quickly. This is the one that was published in New England Journal of Medicine in 2018. So this really was a strategy of community engagement and partnership with 52 Black-owned barbershops. They enrolled 319 Black male adults with hypertension. They created a collaborative agreement with the barbershops as well as pharmacies, as well as local health centers. And this was a cluster randomized trial. It was actually a pharmacist-led intervention, again, showing the focus and task shifting really as a key strategy here. And blood pressure was actually measured by both pharmacists and during some of the within the trial, actually also from some barbers. Now, pharmacists use protocols to achieve blood pressure control, just like I mentioned previously. Standardized antihypertensive medication treatment protocols are an important strategy. And then they transmitted this information electronically to hypertension specialists. And the control group, barbers engaged with their patrons, and they encouraged lifestyle modification and doctor follow-up. Whereas in the intervention, again, they were actively engaged with both pharmacists and barbers. And the primary outcome was a change in systolic blood pressure from baseline to 6 months. And this is what they found, that amongst this 6 months, there was actually a mean fall in systolic blood pressure, and it was 27 millimeters of mercury in the intervention group. 63.6% actually was able to achieve blood pressure less than 130/80, and that was statistically significant. The mean fall in systolic blood pressure was 9.3 millimeters of mercury, which is also statistically significant because these individuals were actually just being encouraged by people that they knew in the community. Now, they published a 12-month study follow-up, and that's the one in Circulation in 2019, where they demonstrated that even after you stop the 6-month intervention, at 12 months, the mean fall in systolic blood pressure was still significant. It's 28 millimeters of mercury in those who were randomized to intervention group, and 68% achieved blood pressure control. Again, in the control group, they were still able to show a reduction in systolic blood pressure by about 7 millimeters of mercury. And most impressively, that the cohort retention at 12 months, despite stopping the intervention 6 months earlier, was 90% in both groups. So again, reiterating that both team-based care and antihypertensive treatment protocols is a really core strategy for blood pressure control. Now, I mentioned again at the beginning that financial levers, I think, are core to all key strategies. And you can't really achieve any of the others without this. And it can be done at, when you think about financial levers, they have to be thought of across multiple levels of the socioecological framework. This includes the individual level, by really rethinking how we can reduce patient out-of-pocket costs for antihypertensive medications, including, of course, combination pills, as well as home blood pressure monitoring. If you go into any drugstore, the out-of-pocket expense for getting a home blood pressure device can be very substantial. There's, again, inadequate coverage limits, I think, wider implementation, and this is really a strategy that we have to think about more broadly. On the clinical level, there have been, programs where you can create device loaner programs, which I think is a way to try and mitigate the out-of-pocket costs for individuals. But sometimes this can be difficult to arrange. And obviously, one of the things that we advocate for is in the policy level is to really increase reimbursement rates for the CPT codes that I already mentioned, to really encourage and assist individuals and clinicians and other members of the team regarding home blood pressure monitoring and reviewing data from that. So what about lifestyle modification strategies? We took the approach and acknowledged that individual behavior change is hard. And if you look at all the guideline and scientific statements, that is part of the first preventive strategy for hypertension as part of treatment. But we acknowledge that clinicians often don't have the time or often untrained also in counseling, whether it be nutrition, physical activity, and sleep, or the behaviors that have been shown to affect hypertension. Now, obviously, again, reiterating that this is a key place where task shifting and team-based care to other members with behavioral modification expertise would be most impactful. We do review that there are several, lifestyle modification strategies that are intriguing to think about at the population level. For those who are in New York, salt reduction at the population level has been thought of and tried to be implemented using New York City National Salt and Sugar Reduction Initiative. Now, these were voluntary targets that looked at packaged and restaurant food items, and multiple studies have shown that they were able to reduce and impact blood pressure control. Now, for some of you, you may already know this, but the FDA has provided guidance and is reviewing this currently on voluntary targets for sodium reduction nationally in processed, packaged, and prepared foods. Now, this is obviously controversial, especially since these are voluntary targets in terms of thinking about how to really engage both big businesses and small business owners to really rethink what their target is for sodium reduction can be. And I think this will be an intriguing area over the next few years to follow as to whether there will be further national guidance on how do you really implement and whether we should be implementing sodium reduction on a national scale. Now, obviously, with lifestyle modification, we can't really, ignore the fact that the built environment plays a part on the efficacy of lifestyle modification strategies. Now, the built environment is obviously affected by historic redlining. Also, climate change affects the built environment. Now, we do advocate for increasing access to green spaces and improving neighborhood walkability, and obviously that requires both policy and financial levers. Now, the Regard study showed that walkability, when it was measured using Street Smart Walk Score, and this is a study on more than 6,000 individuals, Black and white participants in the South. And this study showed that when you have neighborhoods that are more walkable, and this was a score greater than 70, and you look at outcomes such as incident hypertension, the more walkable a neighborhood was, it was associated with a lower risk of developing hypertension. And this was actually similar whether you looked at Black or white adults with living in the South. So obviously, again, this requires engagement with both local policy members to really say, how do we think about and reimagine the built environment in neighborhoods, also acknowledging that climate change is currently one of the major things that we need to be thinking of if this is one of the strategies to improve blood pressure control. We also discuss continuous quality improvement as another key strategy to improve blood pressure control. And obviously, we focused on it on the clinician and health system levels. We define this sort of as a combination of both patient education, team-based care, facilitated relay of clinical data that requires auditing and feedback to improve processes of care and improvement in blood pressure control. When you look at meta-analysis of 44 articles as to whether QI programs were effective in producing clinically meaningful reductions in blood pressure, this is what they found, that the mean effects across all interventions, you can achieve a systolic blood pressure reduction of about 4 millimeters of mercury, as well as 2 millimeters of mercury in the diastolic blood pressure. Now, these interventions include, again, team-based care as a QI strategy, and these were the ones that were associated with the largest reductions in blood pressure outcomes. So really what I'm trying to paint a picture is that these key strategies are not siloed, but really build upon each other, particularly as you continue to integrate them. Again, I mentioned this at the beginning, worth mentioning again, that anti-racism efforts have to be included in implementation strategies, albeit they're going to be the hardest to tackle. Obviously, we know that racism can occur at multiple levels, both individual, interpersonal, internalized, institutional, or structural. Data from the Jackson Heart Study, which is one of the largest cohorts of Black adults in the US, that showed that higher versus lower lifetime discrimination was associated with a higher incidence of hypertension for Black adults, and the hazard ratio there was 1.34. And obviously, this is a national conversation, international conversation, but organization, community, and level policy systems need to be restructured. I'm not going to get into that in this current webinar, but again, there's a separate presidential advisory that I referred to you here and point out that was published in 2020. So how does this all fit together? And I want to show this towards the end is what is a multi-component approach that I want to highlight that uses several of these key implementation strategies that I just went through as an example of how to improve blood pressure control. And this is the American Medical Association Measure Accurately, Act Rapidly, and Partner with Patients program. That's what MAP stands for. This was initially framed as a 6-month hypertension quality improvement program. It was initially conducted as a pilot program in one clinic of 700 individuals in South Carolina. Half of them were on Medicaid, half of the population were Black adults, ranging in age from 18 to 85 years old. And this utilized existing team care. They didn't add any more to these clinics, to this clinic staff. They focused on improving blood pressure measurement and decreasing therapeutic inertia using, again, a protocol-guided therapy. Now, clinicians in this received a monthly scorecard that included blood pressure control for their panel of adults with hypertension. And they also had calculated a therapeutic inertia score, meaning anyone who potentially could have been treated but wasn't treated, that was highlighted for clinicians. And then they showed them what their wins were, that the change of systolic blood pressure with each therapeutic intensification to demonstrate what they were doing well and how that was affecting their patients. And just by doing this, blood pressure control improved from 61% to almost 90% at 6 months. And because of this framework, they actually expanded it and wanted to see if it was replicable and whether it can be done on more of a national basis. So the MAP framework was actually tested in 16 family medicine clinics. These were practice facilitation was withdrawn after 6 months to determine if blood pressure control rates, what they looked at 6 months and 12 months. They enrolled over 16,000 adults, multi-ethnic adults across different age ranges. And what they were able to show, again, was that blood pressure control amongst this national initiative improved from 64% at baseline to about 74% at 6 months. And even after you withdrew the intervention, at 12 months, there was still retention of the cohort, but blood pressure still improved and continued to stay. Control rates were 74% at 12 months. Now, if you estimate what the total cost per 1,000 patients were, there was about $3,600 in investment. And this is a nice, I think, and a practical evidence-based program that works. It improves blood pressure control. It's now been implemented in over 3,700 healthcare organizations, and it shows that the typical timeline from start to implementation in organizations is about 6 to 12 months. And I want to highlight some of the things that come off from this, which may, be something that some of you may want to be looking into. But here's the Target BP, where they actually provide information of to how do you implement some of the key strategies that we discussed over the past 35 minutes. That's including how do you implement home blood pressure monitoring within your medical practices. How do you get prepared? How do you show patients how to do this, what are the protocols that may be needed amongst the team, as well as you integrate this framework. Here again, they discuss and show you the integration of team-based care. Identifying a champion is part of this framework. Again, thinking about financial levers, right? Here's the loaner device program that I discussed earlier, is thinking about budgeting for these so that people who are either uninsured or to protect patients from worsening out-of-pocket expenses. It shows how to train patients, how to select devices, how do you select the cuff sizes, and how to manage devices. So it's a very practical way of approaching this. Again, there's actually an implementation toolkit, and just as I started as one of the key barriers among some of our scientific statements and guidelines historically of not providing, clinicians and practices, what are the toolkits involved? And again, you can go to these website and download these for implementation purposes. This comes also from the Million Hearts Forum. And here, when we talk about antihypertensive treatment protocols, again, practical toolkits where people can actually customize this for their clinical practices and disseminated for team-based care. If task shifting, it becomes a part of the strategy that is adopted by healthcare systems. So to end, I want to just cover some of the priorities and critical gaps. This is what we discuss in the scientific statement, that we think obviously large-scale dissemination is currently lagging nationally. Now, current implementation toolkits exist for some of the strategies. I just demonstrated and showed you examples for home blood pressure monitoring, team-based care, and antihypertensive medication protocols. But interestingly, if you look at the data, that many people are not accessing these current implementation toolkits. So really, it's the issue of dissemination and how do we do a better job providing clinicians and practices this information in a practical way, but really in an accessible way. Now, we also discussed that there, improving coordinated multi-level interventions are needed across organizations. I think many times silos exist within practices where maybe one practice is doing something, but it's not, being implemented across a healthcare system. And I think that leads to multiple barriers. And so we advocate that multi-level interventions and coordination across practices are really needed. Obviously, scaling up interventions while tackling the adverse social determinants of health and adopting anti-racism strategies, I think, is really going to be a key to this. But unfortunately, right now, what that looks like hasn't been studied in a way that I think at the moment can be disseminated practically. We strongly advocate for increasing financial strategies at all levels, particularly at the organizational level and the community level. By taking a top-down approach, I think that can allow clinicians to be more thoughtful in their approach and free up some time, because I think that's really been one of the barriers in improving blood pressure control at the practical level, the clinician level. And obviously, financial strategies for patients is critical. As I mentioned, that 12% of individuals aren't even picking up their antihypertensive medications, and that is because for some, the financial burden of some of these strategies is too high and unacceptable. So improving health systems data infrastructure, I think, to rapidly identify and act upon key blood pressure control process measures is a critical gap. The training of clinicians and multidisciplinary teams on protocols and home blood pressure monitoring, we think is a practical way and probably the biggest bang for the buck, as well as these large-scale implementation of lifestyle programs across health systems and communities. Lastly, this evaluation of anti-racism and health equity implementation strategies on blood pressure control within communities is going to be essential when looking at any strategies to look at blood pressure control. And with that, I will stop and provide an opportunity to have people submit questions and ask questions. Thank you.
Thank you, Dr. Abdalla, for your presentation. We will now begin our Q&A session. As a reminder for our audience, please submit your questions for the presenter through the Q&A feature on your control panel. Okay, Dr. Abdalla, who is the clinical team made up of for the MAP framework? Is it PCPs, pharmacists, et cetera? And do you have any recommendations for who should be on these teams?
Yeah, it's a great question. I'm glad we're talking about that. So the original MAP framework that I presented, it actually didn't add any personnel. So they just used whoever was in there. So there was a medical assistant, a physician, and a nurse. That was sort of a key skeleton. However, if you think about the MAP framework across and how it's developed and how it's expanded, the recommendation really is to integrate pharmacists, right? So the data, for example, from the barbershop study that I presented, having the ability of someone to titrate medications and free up clinicians, I think is really, really important and part of a strategy. And it would be great to do that. However, for some practices, that's not practical to add a pharmacist at the level. And so what I want to show is that if you think about task shifting and you only have a skeleton crew of individuals to help, it can still be done. But what you would need to do is really create, treatment protocols, or I would say is task shifting, for example, to medical assistants to make sure the blood pressure monitoring and ability to actually do the protocols for devices and measurement of blood pressure accurately is clearly delineated, as well as appropriate training provided for those who are part of the team.
Wonderful, thank you. You touched on the barbershop initiative and also some lifestyle education work. Can you expand a little bit on that? How have community efforts that include things like lifestyle modification, maybe around food choices or food stamps, how have those influenced at-home blood pressure monitoring?
Yeah, that's a great question. So we know that lifestyle modification, when from the data, that it works. That's why it's in the guidelines and has been consistently been in the guidelines. And it's I would also add, that when you look at it, that lifestyle modification strategies, people tend to have a difficulty maintaining for a long time. And so it's one of the reasons I think you look at the guidelines, there's this 3-month attempt to use lifestyle modifications before we even put people on antihypertensive medications for those who are newly diagnosed. And so data has shown that that does influence both office blood pressure. It improves office blood pressure, but it also does improve out-of-office blood pressure data, including home blood pressure monitoring. And I think it's when you integrate that, patients tend to be able to have that feedback loop. So home blood pressure monitoring, obviously, individuals can see their blood pressure data because they're pressing their measurements. Ambulatory blood pressure monitoring often it's a 24-hour period. People are not really seeing their own data. But with home blood pressure monitoring and lifestyle modification strategies, it really does go in hand because there is a feedback loop. The more people are doing it, they see an improvement, they can monitor it themselves.
Wonderful, thank you. We've got a question coming in about, how can you involve a community pharmacist at their local pharmacy to do this? What would be needed to get that started?
Yeah. Great question and very timely, given sort of the national discourse on pharmacists right now. I think, in order to do that, it depends on the community because there are some that are just going to be pharmacists within sort of national chains. And I think those are going to be harder for a solo practice to engage. However, I think, for practices that may be involved with the neighborhood where there are, solo pharmacists or pharmacies, that is probably a better strategy. So one of the things that has been tried internationally and also locally in the U.S. is whether, whether you can at least have proper devices available in a pharmacy, right? So you're really saying, can we move home blood pressure monitoring to an area that's more accessible? And if you actually notice, some pharmacists, you can actually measure your own blood pressure and have engagement with the pharmacist at the point of care. So actually, CVS, for some CVS national stores, actually have this. Not every CVS, but I would recommend that if it's a solo practitioner or solo clinical practice, that it might be easier to engage and say, can we start with the first strategy of having validated, devices available to my, community that is, validated based on these two websites that I mentioned, as opposed to having devices in the pharmacy that may not be appropriate for blood pressure control.
Wonderful, thank you for that insight. Next question is, from your experience, how would you recommend overcoming clinical inertia to help patients understand the importance of follow-up and regular monitoring despite being asymptomatic?
Yeah, that's a great question. I think that's $1 million question because I think clinician inertia comes from various things. As a clinician, right, I could say that sometimes it's just time. And it's not that the person doesn't want to do right by a patient. It's just they don't have the time in the day and they don't have the staff to be able to task shift this. So I think engagement with clinicians, and as I mentioned in the MAP framework, what they did very eloquently, panels where you get feedback on how you're doing across your panel and potentially identifying and referring out those who are harder to control. Because I think sometimes the inertia comes with the most difficult to control hypertension patients, and those really maybe should be better served by referral out to hypertension specialists in terms of thinking across panels. For those who are not symptomatic, I always take the approach with my patients in being very transparent with all their data and say, hey, you may not be symptomatic, but your cardiovascular risk may still be high, and trying to reframe the conversation and saying that you are not just at risk, now because you're not feeling it, but it's really that it's the long-term risk that you're building up and accumulating across time. And we know that, for example, people who are younger who develop hypertension obviously tend to have higher rates of mortality from cardiovascular disease outcomes later on. So and they're the ones who are most likely to say, I don't feel it, right? But these are the people that I really sort of think about and target most particularly for blood pressure control, because we know that their long-term risk is highest.
Thank you. Are there any studies around genetic testing for patients that have a hard time controlling their blood pressure?
That's a little bit out of my area of expertise. And there are individual, researchers who are looking at that. Right now, there is no guideline approach to using that information at the moment. but it's an intriguing area, and I think going to be in definitely an upcoming area of thought and more research to come.
Thank you. Around your recommendations and education for your patients, are there particular exercises that you recommend for your patients to help lower their blood pressure?
I like to meet my patients where they're at. So for someone, for example, an elderly patient who's dealing with multiple, mobility issues, for example, may be different than a young person who's just been diagnosed. I try to ask them, I first ask them, can you just walk? And can you walk safely? Because walking in itself, right? You don't have to be a marathon runner, but walking. And so, for example, for some of my patients who, they go and, to a supermarket, I just ask them about their week, right? And say, hey, if you're going to the supermarket, try to park a little bit further away so that you're naturally integrating some of these, what we call exercises, but we know that are actually helpful. And to start slow, particularly, I take care of an elderly population. And so for me, it's more meeting people where they're at. If they can't do that, I say, okay, let's examine sort of what are the choices we're making at home, right? And for some, it is difficult because of their financial, situation. But I also ask, instead of focusing in the grocery store of, all the goods in the middle of the aisles, can you historically where a lot of the healthier foods are on the outside, can you make healthier choices by just shopping on the outside? Others, they may have sleep problems. We know that sleep is a new behavioral risk based on the Life's Essential 8 that just came out a few years ago. Is that, are you getting proper sleep? Why not? Potentially you have obstructive sleep apneas. That's what's causing an increase in blood pressure or worsening blood pressure control. Maybe that needs to be taken care of before even exercises. So I really like to take a personalized approach as to what are they, where they can meet where they feel that they can meet themselves, because again it's building upon that and saying that here's a sustainable practice.
Absolutely. And on that thought of personalization, how do you approach blood pressure control for patients who present with several social determinants of health factors?
Can you repeat that question? How do I approach blood pressure control?
Oh, for patients who present with several social determinants of health factors?
hmm I think it depends on what the social determinant of health factor is. So my practice, I practice in Washington Heights, and in New York City, and so most of my patients have multiple social determinants of health risk, factors. And again, it's hard. I don't have um, an answer to that can be applied more broadly. I think it really is the engagement there of team-based, of social workers are important for my practice, and thinking about what are the things that we can meet and help them with. So, for example, if people are, have issues with out-of-pocket expenses, that's not someone that I'm gonna, strap on an ambulatory blood pressure monitoring device. I may say to them, hey, here's a loaner device for your blood pressure control. I just need you to be able to do this for a few days, so we can start the process of understanding where your blood pressure is, right? I may be looking at them instead of, starting them on a different medication. I may say, let's look at what your plan is. But that takes time and that does require a team-based approach. And I'm grateful that, we have social workers that are involved, that can help us navigate that.
Thank you. And we have time for just a couple more questions. How can providers address patient lack of trust in the healthcare system to highlight the importance of lowering blood pressure?
Yeah, it's a really excellent question. I think trust first goes both ways. And so that's why one of the things we try to encourage is transparency in their data. I just say to them, hey, you show me what your blood pressure is. Do you think this is where we need to be? All right. How can we work with you? Right. Trust is key. And I think it takes time, for people who may not trust the medical system or have had bad experiences is to really have an empathetic approach, is that those experiences are valid, right? They may be coming to you because they haven't been heard, in a different system. And instead of trying to be antagonistic towards it, say, how can we move towards better communication? And so for those individuals, I tend to take the approach of let them show me the data, and get them more engaged. There are some studies that show that, having individuals actually, if there's equipoise in which medication they should be on first, having them choose, say, do you want this medication or that medication? It doesn't matter. You just need to be on a medication. And so they have a little bit more say into their medical care. And I think, the lack of trust is also just, have they been heard sufficiently? Have they been seen sufficiently? And I think that's really what it's about.
Thank you, Dr. Abdalla. That's all the time we have for questions for today. We want to thank you so much for the great discussion and presentation, and thank you to our audience for your participation. When you exit this webinar, a feedback survey will pop up in your browser. You will also receive a follow-up email tomorrow with the survey link. The recording from today's webinar will be available in the coming weeks at heart.org/pain management. Please be sure to visit this site for additional resources on this topic, future educational opportunities, and to join our mailing list. Thank you very much for attending. This concludes our webinar.
Thank you so much.